Hello, and welcome to the CAP Today webinar for Wednesday, May 21st. I'm Bob McGonigal, the publisher of CAP Today, and I'll be your host and moderate a question and answer session after our formal presentation. We have a very critical webinar today addressing a very important and newsy issue. The webinar is entitled A Pathologist's Perspective: Exploring the Expanded Clinical Utility of HER2 IHC Scoring in Metastatic Breast Cancer. Our webinar today is sponsored by Daiichi Sankyo and AstraZeneca. I'm very pleased to acknowledge their support, and we want to thank them for their help in bringing you this very important webinar. I do want you to note that this program is designed, broadly speaking, for U.S. medical professionals only and is not CME accredited. Our speaker today, and for us, it's a pleasure to work with him once again. We have a great partnership going and a great reception and a great lecture today. Our speaker, of course, is Dr. Pranil Chandra. Dr. Chandra is the Senior Vice President and Chief Genomics Officer at PathGroup, very, very well-known laboratory, and it's a great delight. Now, before we begin the formal presentation, I'm just going to give you briefly a couple of housekeeping tips. You'll see on your screen as participants a Q&A box. In that box, you can do two things. First, you can ask for technical help. We have live people standing by to help you with any audio or visual problems that may crop up. They'll help you fix that very speedily. Of course, the Q&A box is chiefly designed for your questions and your comments. You can make them at any time during today's presentation. And after Dr. Chandra finishes, then I'll begin those Q&A. And I keep track of those and triage them throughout the hour. You should know that we'll be posting the full audio and video of this presentation in about a week or so at CAP Today online. It will be, of course, subject to some review. You should expect to see some email follow-up from us and perhaps also Daiichi Sankyo and AstraZeneca, so be aware. And finally, as always, I must tell you, CAP Today does not endorse any products or services that may be named today. Any remarks of mine are purely personal, and of course not to be taken as official policy of the CAP Today or the College of American Pathologists. And with that, let me introduce, and Nadine will advance the slides for me here for the first couple, or someone will, exploring the expanded clinical utility of HER2 low and HER2 ultra low scoring in metastatic breast cancer. The program disclaimer that I'm about to read is important, so I want you to pay attention. This program is being sponsored and paid for by Daiichi Sankyo Inc. and AstraZeneca. This presenter is a paid consultant for Daiichi Sankyo and AstraZeneca. The information in this program is consistent with the U.S. prescribing information for Enhertu and the method sheet for pathway HER2 4B5 CDX to identify patients with HER2 low and HER2 ultra low metastatic breast cancer. This program is not CME accredited and may not be used for CME accreditation. And of course, there's some important safety information that you'll see and full prescribing information, including boxed warnings and the medication guide available at this presentation. And so with that now, I'm going to invite our great friend, Dr. Chandra, to begin his presentation. Dr. Chandra.
Bob, thanks so much for that introduction, and really appreciate the opportunity to present here today on behalf of AstraZeneca and Daiichi Sankyo, but also with the blessing of CAP Today. It's been a wonderful partnership and really enjoy our long-term partnership, Bob.
Great.
I also wanted to thank you all, the audience, for being here with me today. to discuss this really important topic. And we're going to spend the next 40 to 50 minutes talking about HER2 low, HER2 ultra low, and the cancer biomarker testing that's critically important to render that information. The objectives here today are to educate you all on the clinical significance of identifying patients with HER2 ultra low, and that is defined as IHC 0 with membrane staining. And we'll talk about some nuances in those definitions, and it's in the context of metastatic breast cancer. We're going to raise awareness on the evolution of the HER2 spectrum, including HER2 low and HER2 ultra low. We will highlight key considerations that impact HER2 IHC scoring and interpretation, and then we'll review guidance for pathologists to accurately report HER2 low and HER2 ultra low status. And then I will briefly review some resources that are out there to help you in your evaluation of HER2 IHC in metastatic breast cancer. So in order to achieve that, we are going to talk about the classification of HER2 expression in breast cancer. And I will overview some key critical clinical trials, including the Destiny Breast 04 trial, which was a phase 3 trial that evaluated patients with HER2 low metastatic breast cancer who were historically classified as HER2 negative. We'll talk about the Destiny Breast 06 trial, which again was a phase 3 trial in patients with HER2 low, defined as IHC plus or IHC 2 plus ISH negative, and HER2 ultra low, IHC 0 with membrane staining metastatic breast cancer. We'll talk about the HER2 testing guidelines, including factors, pre-analytic factors, and other factors that may impact testing results. We're going to review reporting and interpreting HER2 ultra low using the Roche companion diagnostic, which is the pathway 4B5, to identify eligible patients. We have some challenging cases and examples that I will be reviewing with you. And then we'll talk about the context of potentially reevaluating patients with HER2 ultra low, as this will be a very frequent request to the pathology team from the clinical cancer care team. So let's start first by talking about the classification of HER2 expression in breast cancer. So this has evolved over time, the HER2 scoring, and it's evolved from a binary classification to a spectrum of expression. And so let me walk you through that timeline from 2007 to 2013 to 2018, and then most recently some of the changes in 2023. So in 2007, and this is the timeline of the ASCO-CAP IHC HER2 guidelines. And in 2007, HER2 IHC at that time was defined as greater than 30% of tumor cells. And this cutoff of 30% was designed to reduce false positives. In 2013, the IHC 3 plus was redefined, and it was redefined to intense circumferential membrane staining in greater than 10% of tumor cells to reduce false negatives. IHC 2 plus has also evolved over the times. In 2007, IHC 2 plus was defined by complete membrane staining that is either non-uniform or weak in intensity, but with obvious circumferential distribution in at least 10% of cells. And then in 2013, that was updated to redefine IHC 2 plus as circumferential membrane staining that is incomplete and or weak, moderate, and within greater than 10% of cells, or complete and circumferential membrane staining that is intense and within less than 10% of tumor cells. In 2018, IHC 2 plus was then redefined to represent weak to moderate complete membrane staining observed in greater than 10% of tumor cells. IHC 0 and 1+ has also undergone evolution over the times. It was originally defined in 2007 as no staining or weak incomplete membrane staining in any proportion of tumor cells. And then in 2013, IHC was redefined as incomplete membrane staining that is faint, barely perceptible, and within greater than 10% of tumor cells. And then IHC 0 was redefined as no staining or membrane staining that is incomplete and is faint, barely perceptible, and within less than 10 or equal to less than 10% of tumor cells. So in 2023, again, what the CAP-ASCO guidelines have done is they have refined the best practices to help distinguish between HER2 IHC 1+ as well as IHC 0. So you can see here that over the course of many years, we have undergone an evolution from HER2 positive and negative to a spectrum of HER2 expression that takes into account lower and lower levels of HER2 expression. So along with that, the clinical significance of HER2 in metastatic breast cancer has also evolved beyond HER2 expression and/or amplification to include these low levels of HER2 expression. So let's start on the extreme right-hand side. We all know what HER2 positive is. It's IHC 3+, that in greater than 10% of tumor cells, strong circumferential membrane staining that is complete and intense. And HER2 positive is also defined by IHC 2+ tumor samples that are ISH positive. Okay. But now let's take a look at some of the lower areas of expression. You now have, as a result of these clinical trials, you have patients with HER2 low expression, as you can see here. And these are patients who are either IHC 2+ and ISH negative, or they are patients with what's traditionally defined as IHC 1+ through ASCO CAP guidelines. Okay. You also have HER2 ultra-low expression, which was a result of patients identified in the DESTINY-Breast06 clinical trial. And these are patients categorized who were in the clinical trial categorized as HER2 ultra-low, and those are patients with IHC 0 with membrane staining. So again, because of these two clinical trials, we are now evolving to a classification system that allows for identification of these patients who could potentially benefit from therapy, and I'll have more information on that later on in the presentation. So that brings us to our first polling question. Bob, is this something you'd like to cover?
Yes, thank you. Our first polling question is pretty straightforward. How common is HER2 ultra-low IHC 0 with membrane staining among patients with HR positive, HER2 negative metastatic breast cancer? You see there your choices: A, 5%, B, 5 to 10%, C, 10 to 15%, and D, 20 to 25%. Please go ahead, cast your ballot now. Thank you. And now we'll go ahead and close that, and I'll ask Dr. Chandra to resume. Thank you.
Thank you, Bob. So the correct answer here is 20 to 25%. And I'm going to show you the incidence of not only HER2 ultra-low, but also HER2 low as it related to the DESTINY-Breast06 clinical trial. The important thing here for the audience to appreciate that is that there's a very significant number of patients who have metastatic breast cancer who were originally classified as HER2 negative who actually could benefit from the targeted therapy. So again, we'll get to that in later slides. I wanted to cover the actual therapy, which is trastuzumab deruxtecan, also known as Enhertu. And it's known as a class of therapy, better known as ADCs, or antibody drug conjugate therapies. And this particular agent combines a humanized monoclonal antibody with a topoisomerase 1 inhibitor payload bounded by a cleavable linker. And there are three components, as you can see here, to the structure of this compound. You have the HER2-directed monoclonal antibody, which provides targeted delivery of the cytotoxic agent. It consists of the same amino acid sequence as trastuzumab. Then you've got the topoisomerase 1 inhibitor payload, which is a highly potent payload, and it's an exatecan derivative known as deruxtecan with a short systemic half-life. And upon release, a membrane permeable payload causes DNA damage and cell death, resulting in destruction of targeted tumor cells and neighboring cells present in the tumor microenvironment. And this is known as the bystander anti-tumor effect. And it's actually a very powerful way of not only targeting the HER2 expressing cells, but also the bystander tumor cells next to those HER2 expressing tumor cells. And then finally, you have a tumor selective cleavable linker that attaches the payload to the antibody, and that linker payload is stable in plasma and selectively cleaved by enzymes that are upregulated in tumor cells. And this therapy does have a homogeneous and high drug to antibody ratio. It's actually 8 molecules of cytotoxic agent per antibody. So again, it's a very amazingly engineered therapy, and really sets the stage for other similar antibody drug conjugate therapies that are in various stages of clinical trial development. Okay, so now we're going to spend some time talking about the Destiny Breast 04 as well as the Destiny Breast 06 clinical trials. These were landmark clinical trials, and just a few comments about Destiny Breast 04. This was presented back in, I believe, 2022 at the ASCO conference. And simultaneously, there was a publication in the New England Journal of Medicine. And this is one of the very few ASCO presentations that received a standing ovation. And that's how important and historically critical this study was for patients who have advanced breast cancer. So let's dig into a little bit more detail about Destiny Breast 04. That was a multi-center, open-label, randomized phase 3 study, and it evaluated specifically patients with HER2 low. Again, HER2 low patients are defined as IHC 1+ by ASCO CAP guidelines, or IHC 2+-ish negative. The trial included 557 adult patients, and this was a trial that compared Enhertu versus treatment of physician's choice of single-agent chemotherapy. And these patients had unresectable or metastatic HER2-low breast cancer confirmed with the pathway HER2, that's the 4B5 clone that was developed by Roche Ventana. And these patients were assessed using the 2018 ASCO CAP criteria. They were randomized 2-to-1 Enhertu versus treatment of physician's choice. They were also required to not have tumors previously classified as HER2 positive on any prior pathology, and they must have received chemotherapy in the metastatic setting or developed disease recurrence during or within 6 months of completing adjuvant chemotherapy. Patients who received prior HER2-directed therapy were ineligible. In hormone receptor positive patients, they must have received at least 1 endocrine therapy, and treatment was administered until disease progression, death, withdrawal of consent, or unacceptable toxicity. The randomization was stratified by HER2 IHC status, the number of prior therapies, and including cyclin-dependent kinase inhibitor use for these patients. And then the HER2 low tumors were indeed heterogeneous, and they included both hormone receptor and hormone receptor negative tumors. Again, triple negative breast cancer tumors were included in this cohort. And so let's talk about some of the results of the clinical trial. The primary endpoint of the study was progression-free survival in the hormone receptor positive HER2 low population. And you can see that they had a median progression-free survival of 10.1 months versus 5.4 months with chemotherapy, with a key secondary endpoint of progression-free survival in the overall population, as assessed by blinded independent central review. So you can see that HER2 demonstrated a statistically significant and clinically meaningful progression-free survival benefit on both endpoints. What you see on the slide here is data from the overall study population. So again, this includes not only the hormone receptor positive patients, but also the triple negative, hormone receptor negative HER2 low status patients. And you can see that there was a 50% reduction in risk of disease progression or death with HER2 versus chemotherapy in the overall population, and a 49% reduction in risk of disease progression or death in the hormone receptor positive cohort. Median progression-free survival was 9.9 months in the HER2 arm versus 5.1 months in the chemotherapy arm. Again, very compelling and very significant data that led to the FDA approval back in 2022. So I want to review also, importantly, the safety profile of HER2 in DESTINY-Breast04. And it's important to realize that there are side effects, and some of those side effects can actually be pretty serious. And it's very, very important for everyone on the cancer care team to be aware of some of these side effects. The majority of adverse reactions, such as nausea, vomiting, constipation, and diarrhea, majority of them were grade 1 and 2. The median duration of the treatment was 8 months for patients who received HER2 and 3.5 months for patients who received chemotherapy. And you can see here some of the most common adverse reactions. The slide here shows additional common adverse reactions, including decreased appetite, musculoskeletal pain, hemorrhage, nervous system disorders, as well as others. The most common lab abnormalities in greater than or equal to 20% of patients included leukopenia, decreased white blood cell count, decreased hemoglobin, decreased neutrophil count. And of note, interstitial lung disease, which was one of the major side effects that was reported in 12% of patients receiving HER2, of which 3 cases were grade 5. So now that we've talked about the DESTINY-Breast04 clinical trial, I wanted to take a few minutes to review the DESTINY-Breast06 clinical trial, which was a phase 3 trial in patients with HER2 low as well as HER2 ultra low status of HER2 expression. So as I mentioned, this was a phase 3 multi-center open label and randomized study which evaluated the efficacy and safety of HER2 as compared with the physician's choice of single agent chemotherapy in 866 patients with hormone receptor positive, HER2 low, or HER2 ultra low metastatic breast cancer who had received 1 or more endocrine-based therapies, but no previous chemotherapy for metastatic disease. The HER2 expression for the HER2 ultra low population was centrally confirmed on the basis of analysis of a sample obtained after metastatic disease had occurred. Patients were randomized 1-to-1 to receive HER2 versus treatment of physician's choice of single agent chemotherapy until occurrence of disease progression or unacceptable toxicity. And patients were eligible if they had disease progression after receiving at least 2 previous lines of endocrine-based therapy for metastatic disease. Patients who had received 1 previous line of endocrine therapy for metastatic disease were also eligible if they had disease recurrence within 24 months after initiation of adjuvant endocrine therapy, or if they had disease progression within 6 months after initiation of first-line endocrine therapy plus CDK4/6 inhibitor for the treatment of metastatic disease. Eligible patients could not have had chemotherapy for advanced or metastatic disease. And the patients were stratified by CDK inhibitor use, HER2 expression, and previous taxane in the non-metastatic setting. The other important thing to note, and this is data from the DESTINY-Breast06 screening data, and it ties in to the previous polling question. There's a very significant percentage of patients who were potentially eligible for this therapy. So let's start on the right-hand side with HER2 low patients. Again, these are HER2 low patients who were defined as IHC 1+ or 2+-ish negative. And these patients represented about 60 to 65% of the cohort. And then when you fold in patients who had HER2 ultra-low expression, and again, that's membrane staining that is incomplete and is faint, barely perceptible in less than or equal to 10% of tumor cells, you had a total of about 85 to 90% of patients with hormone receptor positive HER2 negative metastatic breast cancer who may have actionable levels of HER2 expression. So that's a pretty significant number. The other thing I'd like to point out is that these patients here who are in the clinical trial defined as HER2 null, these are patients where absolutely no staining is observed. These patients were not eligible for the therapy, and so it would be really interesting to see in future studies how these patients over here actually benefit from the therapy. I think that's going to be a very important future study for the original investigators to think about. Okay, so let's talk about some of the data from the DESTINY-Breast06 clinical trial, which again, very significant. You can see here that the trial did actually meet the primary endpoint of improved progression-free survival compared to chemotherapy, according to blinded central review in the HER2 low population. The median progression-free survival difference, 13.2 months versus 8.1 months, was indeed statistically significant, as well as the hazard ratio. In patients with HER2 ultra-low metastatic breast cancer, the median progression-free survival was similar. It was 15.1 months for the Enhertu arm and 8.3 months for the chemotherapy arm. The HER2 ultra-low cohort, importantly, was an exploratory population, and the data are descriptive and were not tested for statistical significance, nor were they powered to show a difference between treatment arms. Therefore, the clinical significance is not known. So very, very important data in the DESTINY-Breast04 as well as 06 clinical trials. Importantly, let's review some of the common adverse reactions in the DESTINY-Breast06 trial. And the most common adverse reactions included nausea, diarrhea, vomiting, and constipation. The median duration of treatment was 11 months for patients who received Enhertu and 5.6 months for patients who received chemotherapy. There were additional common adverse reactions, including upper respiratory tract infection, nervous system disorders, interstitial lung disease, as well as others. And about 6.5% of patients in the DESTINY-Breast06 trial had adverse events that necessitated discontinuation of treatment due to interstitial lung disease, pneumonitis, and that included 2.8% patients of who had interstitial lung disease, 3.7% with pneumonitis. There were no discontinuations due to ILD pneumonitis in the chemotherapy arm. In the clinical trial, among the 49 patients in the HER2 arm who had events adjudicated as drug-related ILD, 40% of them had recovered, 4.1% recovered with sequela, and 6.1% were recovering from the event at the time of the data cutoff. Of the remaining 24 subjects who had events adjudicated, 46.9% had not recovered, and one patient had actually died. So again, it's very important to be aware of some of these minor but also pretty significant side effects that could happen. The most common lab abnormalities, greater than 50% in these patients in DESTINY-Breast06, included decreased white blood cell count, decreased neutrophil count, and decreased hemoglobin and decreased lymphocyte count. Okay, so we covered a lot of clinical trial data, and now I wanted to shift gears a little bit. We're going to talk now about some of the factors that could affect IHC reporting. So there are a number of guideline recommendations for pre-analytics, and we're going to cover them here as it relates to the primary tumor biopsy, the metastatic site biopsy, sample handling, as well as sample storage. The slide here shows the type of biopsy most frequently used for biomarker testing in patients with metastatic disease are indeed core biopsies. And core biopsies have several advantages over excisional biopsies, but they have limitations as well. Some of those limitations include sampling bias, because of the fact that you can have tumor heterogeneity and variability of tumor expression. So a core biopsy may not capture the full spectrum of HER2 expression. And core biopsies are also prone to certain artifacts, such as edge artifacts, crush artifacts, such as what's shown on some of the pictures here. So the guidelines recommend that on the basis of some criteria, such as high-grade tumors, a new HER2 test could be considered and ordered on the excision specimen if the initial HER2 result in a core needle biopsy of a primary breast cancer is negative. Now we're going to review some of the other effects of evaluating HER2 in a metastatic core needle biopsy, which can sometimes be done from a bone biopsy due to metastatic tumor involving the bone, which may require the decalcification process when such a biopsy is actually procured for evaluation. And importantly, for all the laboratorians on the call here, we need to understand the impact of certain decalcifying agents, which can indeed compromise HER2 detection and scoring. The pictures that you see here illustrate this impact of different agents on HER2 staining. And so it is recommended that to preserve HER2 antigenicity, decalcify agents using strong acids should not be used. And in metastatic cancer tissue samples, the pathologist needs to understand that there can be an impact because of a variety of factors, pre-analytic factors that are not necessarily monitored as well as in primary breast tissue samples. So again, something to keep in mind. Sample handling and the importance of cold ischemia time and type of fixation and tissue preparation. These can all affect your HER2 score. The images on the slide depicted here are from an actual study that came out of University of Pittsburgh in 2013. And it shows that the same tissue exposed to prolonged ischemic times showing a decrease in HER2 staining. So it is recommended that cold ischemia time should be as short as possible, ideally no more than an hour. The fixation time in 10% neutral buffered formalin should be between 6 and 72 hours to minimize the occurrence of false positive or negative results. Samples should be cut at 5 to 10 millimeter intervals during gross evaluation. And after obviously inspection of margin designation and designation of appropriate tumor samples placed in formalin. And so these are, again, really important variables that need to be taken into account when evaluating these samples. And then finally, sample storage is hugely important as well. What you see here are samples that have undergone degradation and of HER2 expression over time. Samples cut freshly at 1 week versus samples that were tested 6 weeks later for a couple of cases. So again, it's recommended, and this is present within guidelines, that sections should ideally not be used for HER2 testing if these sections are greater than 6 weeks old, as this may hamper your evaluation of HER2 expression in these patients. Okay, so now let's talk about reporting and interpreting HER2 low and HER2 ultra low using the pathway 4B5 companion diagnostic. It's important to know that the antibody and the instrument, the 4B5 antibody and the benchmark ultra, remain unchanged. And so this was carefully validated and carefully defined in the clinical trial. The cell conditioning and primary antibody incubation times were locked in the clinical trial. And it's recommended a specific cell conditioning and antibody incubation time is now recommended here for HER2 assessment in all breast cancer cases. According to the 2023 ASCO-CAP guideline update, the best practices to distinguish IHC 0 from 1+ have now been defined, and that is now part of the CAP best practices guideline. And this update does affirm prior HER2 reporting recommendations and offers a new HER2 testing reporting comment to highlight the current relevance of IHC 0 versus 1+ results and best practice recommendations to distinguish these often subtle differences. The scoring criteria from previous 4B5 interpretation guides were aligned in the 2023 ASCO-CAP guidelines. The HER2 4B5 companion diagnostic was the antibody, again, clinically validated in this clinical trial. And it's important to know that deviating from the recommended staining protocol may produce invalid results. And so it's really important to stick to the SOP as outlined in the package insert. And because decreasing or increasing, for example, the cell conditioning times can produce HER2 stain samples with altered HER2 scores, which obviously can impact decision-making due to impact in the antibody expression. And so the CDX should be interpreted obviously by a qualified pathologist in conjunction with histological examination, all the clinical information, and the appropriate controls. So here's are some steps to walk you through how to score and interpret HER2 ultra low, which can be challenging. So it's important to first scan the entire sample at low magnification to identify areas of invasive tumor cells and avoid areas of necrosis and crush artifacts. Then it's important to determine the membrane staining pattern. Is it incomplete? Is it partial? Is it circumferential? as well as the staining intensity. Is it faint, is it weak, or is it moderate and intense? The relative percentage of stained cells should be assessed using your established cutoffs, 0%, less than or equal to 10%, or greater than 10%. High power 40X should be used to accurately determine the pattern and intensity of staining as needed. And pathologists need to be aware that additional time may be needed to assess cases with artifacts, values near the 10% cutoff, as well as heterogeneous areas. And this is a bit of a departure from how these were previously evaluated. And again, I want to note and emphasize that there may be more time that's going to be needed for a pathologist to evaluate these cases. And there may also be a need to request a second pathologist to review these cases for faint partial staining of the membrane and percentage of tumor cells, especially when you're getting down to less than 5%. So again, it's very important to pay careful attention to all of these details, and then especially for pre-analytic conditions of breast cancer tissue samples that are obtained from both primary as well as metastatic sites. Okay, so let's talk about some of the CAP reporting templates and the information that is present in the CAP reporting templates. For those of you who have access to your cell phone, if you want to scan in this barcode, you'll be taken to a link where you can scroll down and find an example of the CAP reporting template. So, how should this be reported? Well, HER2 ultra-low status should be reported by documenting the membrane staining that is incomplete and is faint, barely perceptible, and is in less than 10% of tumor cells. The CAP uses the term 0+ with membrane staining, and I'll detail that in another slide. As you know, there are some subtle differences with how HER2 ultra-low is being called out by CAP as well as other entities. But the important thing here is that you all need to think about updating your reporting templates and adding at least a comment to highlight a patient's HER2 ultra-low status, and considering the terms HER2 ultra-low, or just simply calling out the discrete data of 0+, 1+, and the percentage of tumor cells that are actually staining. So again, patients with no membrane staining by IHC are ineligible, are excluded from potentially receiving therapy. And pathologists can consider using the optional standardized HER2 IHC report comment to explain the clinical relevance of lower levels of HER2 IHC staining in the metastatic setting and definitions of HER2 and ultra-low used in the clinical trials. And you can see some of the verbiage, and I'll just read it out, that is now being included in the CAP reporting template. In Destiny Breast 04 and 06 trials, HER2 low was considered an IHC score of 1+ or 2+-ish negative, and HER2 ultra-low was HER2 IHC score of 0 with membrane staining that is incomplete and faint, barely perceptible in less than or equal to 10% of tumor cells. Breast cancers with these staining patterns may be eligible for treatment within HER2 in the metastatic setting, but those with no staining are currently excluded. So again, very important information that our pathology community should really give some strong consideration in integrating into existing HER2 reports. Bob, I'm going to hand it over to you for our next polling question.
Thank you very much. Now, here's a poll that I think you'll all find interesting to answer, and I'll leave you on the honor system. And so to go ahead and indicate from 0 to 10 or from no stars to 10 stars, depending on how this displays on your screen, how confident are you in distinguishing HER2 ultra-low from HER2 low in your clinical practice? We'll let you go ahead and answer that question. And if you're wavering, you may have colleagues who feel the same. But it's an interesting question for you to answer. We'll go ahead now and close that poll. And Dr. Chandra, would you care to comment on the results you see?
Yeah, so according to the results, we are seeing a higher level of confidence in the audience's ability to distinguish HER2 ultra low and low in our in clinical practice. I will say from just anecdotal experience is that this has been a pretty steep learning curve. When I first presented this talk soon after the FDA approval after DESTINY-Breast06, there were a lot of questions. And so I think it's really important for just the community to continue to learn and integrate and incorporate this and also follow best practices and have educational material. So we are definitely making progress, but there is still a lot of work that needs to be done. Finally, I wanted to comment on the HER2 ultra-low classification differences. There are some subtle differences, whether you're looking at the DESTINY-Breast06 clinical trial, the 4B5 pathway companion diagnostic package insert, the CAP reporting template, as well as the ASCO CAP guidelines. And so importantly, they're relatively consistent, but there are some subtle differences that I'm going to point out, and they are all consistent with the HER2 ultra-low category. So the DESTINY-Breast06 defined HER2 ultra-low as tumor cells with HER2 expression greater than 0, that's really important, and less than or equal to 10%, with the IHC status description of IHC 0 with membrane staining. The 4B5 pathway kind of followed that same scoring criteria definition as a DESTINY-Breast06 clinical trial. The CAP reporting template and then ASCO guidelines defined these as membrane staining that is incomplete and is faint, barely perceptible in less than or equal to 10% of tumor cells. In the CAP reporting template and as well as in NCCN guidelines, these patients are categorized as 0+ with membrane staining, but they're categorized as 0 in the ASCO CAP guidelines. So there is some subtle variability, but I think it's just important for clinicians and pathologists to understand that at a macroscopic level, but also decide at a local level how you would like to report HER2 low as well as HER2 ultra low, because ultimately medicine is practiced at a local level. So I'm going to show now some challenging HER2 IHC case features that illustrate some key points that are important for you to know. The main point on this set of slides here is that in the DESTINY-Breast06 clinical trial, there was no lower limit for staining as long as the staining was accurate and your controls were appropriate. So patients with single cell staining were actually eligible to receive HER2 in the DESTINY-Breast06 clinical trial. And this is an example on a lower power, not higher power, very focal membranous staining that actually would fit the category of HER2 ultra low. This is another case of an IHC score 0 with membrane staining. At the lower power at 20x, you'll appreciate that there is some staining. And then on higher power, this was a case that showed around 1% of partial faint to weak membrane staining and was categorized as HER2 ultra low. This is a patient who had absolutely no membrane staining. And so in the clinical trial, they were characterized as HER2 null. And this is these are patients with an IHC score of 0 without any membrane staining. And as I mentioned earlier, time will tell what the clinical significance of this is and whether even these patients would benefit from therapy. But based on the Destiny 06 clinical trial, these patients currently would not be eligible for trastuzumab deruxtecan therapy. And then finally, this is a bit of a challenging case that shows tumor cells with a bit of a cytoplasmic blush. And on higher power, you can see that there is a complete membrane staining, but those cells represent less than 10% of the tumor cell population. And overall, there are about 15%, 10 to 20%. This was categorized as 15% of tumor cells that show HER2 IHC 1+ expression. So again, wanted to just highlight that it's important to not only look at these on low power, but also on higher power. It may be important to spend more time on these cases and also to get a second opinion with another pathologist. Pathologists are also going to be asked to reevaluate prior HER2 negative calls that were made, especially potentially prior to the clinical trials. And so it's going to be really important for a pathologist to be engaged in that process. You may receive a request from an oncologist or from some other member of the clinical care team. And it's important to know that some of these patients who were previously diagnosed as HER2 negative and signed out as HER2 negative, they were actually done correctly based on the ASCO-CAP guidelines, but there may be an additional requirement to re-review those slides and qualify and refine those results in light of the percentage of tumor cells that are showing membrane staining, especially at the 0 and 1+ threshold. So there may be addendums or additional reports that may need to be rendered as a result of this. Importantly, the HER2 low expression and HER2 expression in general can be variable during disease evolution, especially if you're evaluating HER2 status through core biopsies. And so there have been a number of studies now that have demonstrated this variability. And you can go from HER2 low to HER2 0 negative expression and vice versa. And that happens around 15% of the time, where cases switch from HER2 0 to HER2 low or HER2 low to HER2 0. So again, it's important to keep that in mind and to consider retesting in the appropriate clinical context. And Bob, would you like to cover our next poll?
Yes, thank you very much. I was very encouraged by the results from our last poll. And let me ask you this now. In your clinical practice, which scenarios would you consider for retesting HER2 status? First, disease progression to utilize appropriate therapy. B, new metastasis. C, potential tumor heterogeneity. And finally, D, unresponsive to therapy. It's an interesting poll. Again, I'll be very interested to see these results. And let's take a look at those now and some discussion from Dr. Chandra.
Thanks, Bob. While we wait for those results, I don't see them yet, but they're popping up. I would consider retesting in all of those categories, but I think the most important one, and the audience agrees, is when there's new metastatic disease. In fact, 75% of the audience selected B, and then 25% of the audience selected C. And again, I think these decisions need to be made at a local level, and one can argue really any of these scenarios to actually consider retesting. as I mentioned earlier in the talk, there are a number of educational resources and training. These include interpretation guides, some really very well-written interpretation guides by the Roche Ventana team. And I've seen their interpretation guides. They're very detailed. They have examples of positive and negative cases, challenging cases. So I would refer you to those interpretation guides. I would also like to refer you to the 2023 ASCO CAP guidelines. They've done a great job incorporating and integrating some of the recent data as a result of the Destiny Breast 04 as well as Destiny Breast 06 clinical trials. And then there are tons of on-demand learning that are available to you regarding HER2 low and HER2 ultra low assessment. So again, it's very important. This is not an easy subject, and this requires a lot of training and standardization by the pathology community, and a thoughtful approach at a local level on how to report these patients. So again, please take note and avail of all of these different materials for training. And then finally, as I mentioned, it's really important to understand the safety presentation, the safety information rather. And so before we close out the presentation today, I want you all to note the complete important safety information that's included with this presentation, including the boxed warnings that you can see here front and center. There can be some significant side effects with the therapy. And again, it's important for everyone, including pathologists, to be aware of all of these potential side effects, including embryo fetal toxicity. And that's why patients need to be appropriately counseled, especially women, and just advise patients on the need for effective contraception and have other appropriate conversations with patients. There are a number of additional warnings and precautions. Specifically, as I've mentioned earlier in the talk, interstitial lung disease pneumonitis did occur in 12% of patients, and there was a fatal outcome in 0.9% of patients. So clinicians are obviously following these patients closely and monitoring for really any signs of these conditions. And then finally, there are other adverse events, including neutropenia, which was 19% of the time grade 3 or 4, and febrile neutropenia was reported in 1.2% of patients. Left ventricular dysfunction is another adverse event and was seen in about 4.6% of patients who received the therapy. And as mentioned, there's also the possibility of embryo fetal toxicity. So dose modifications may be required for adverse reactions, including some of the ones that I've mentioned. The most important adverse reactions are detailed here, and you can scroll through some of the adverse reactions that are present on this slide and the ensuing slides as well. And I'll show them briefly.
And Dr. Chandra, for the purposes of our audience here, I want you to know we plan to post these slides along with the webinar at captodayonline.com, so you can review them at your leisure and take your time with those, because they are very important, as Dr. Chandra indicates. Dr. Chandra.
Thank you, Bob. And so to close out the presentation today, it looks like we're right on time. In summary and in conclusion, we covered a lot of information here, and so at a high level, it's really important for everyone in the cancer care community, pathologists and laboratorians included, to understand the clinical data behind these landmark clinical trials for trastuzumab deruxtecan in the HER2 ultra-low as well as HER2 low population, and how that's impacting us as a laboratory on how we're reporting these results. Importantly, the 4B5 antibody is the companion diagnostic that's FDA approved. This is an antibody that's commonly used. It's not used by every laboratory, but it is a common antibody, and it was clinically validated to identify HER2 low as well as HER2 ultra-low expression. There are interpretation guides as well as a plethora of educational material. The resulting of these those decisions need to be made at a local level, but absolutely the laboratory community needs to decide how to report HER2 ultra-low, how to report HER2 low classification, either through reporting templates or supplemental reports or integrating into existing reports. And finally, pathologists may need to reevaluate previously rendered IHC results to distinguish 1+ from IHC 0 and to tease out those patients with HER2 ultra-low, again, to optimize identification of eligible patients. So with that, I wanted to thank you all for your attention and your participation today. And we'll conclude with this final poll.
Obviously, our great gratitude goes to Dr. Chandra. As I said before, we work together frequently, and I think here you've gotten an enormously comprehensive presentation and lecture. I recommend that you come to captodayonline.com. There's a lot to review. There is also a lot to share with your colleagues, and I think it's been really, really wonderful work. In addition to that, of course, I want to thank Daiichi Sankyo and AstraZeneca for their great sponsorship. Both companies have done exemplary work in education, and we're very grateful for their support and the efforts that they have made. Finally, I want to thank all of you. I know, believe me, I know how busy you all are. It's not an easy day in the office any day. But particularly now, it's busy. And so we're very grateful when you find the time to join us for an hour or so in our CAP Today webinars. You really make it worthwhile for us, and we're very grateful. So with that, once again, to wind up, I want to thank Dr. Chandra. I want to thank Daiichi Sankyo and AstraZeneca. And I want to thank all of you as participants. And with that, I'll bring today's webinar to a close.